welcome to the third live event organized by the McGill World Restart a Heart 2021 campaign. For those of you who may not be familiar with World Restart a Heart, we're a student-run, faculty-supported global initiative started within the Faculty of Medicine and Health Sciences here at McGill University. And our main goals here at World Restart a Heart are really to promote discussion and destigmatize sudden cardiac arrest. We really want to encourage people to act and give them the skills to act in moments of sudden cardiac arrest. We think this is a huge and important public health investment and one of the best ways to reduce the morbidity and the mortality of sudden cardiac arrest. My name is Carla Apostolova. I'm a second-year medical student here at McGill University, and I'm also part of the student committee for the 2021 campaign. I'd like to start by thanking and welcoming our panelists for being here today. I'd also like to thank our audience for tuning in and for being curious about sudden cardiac arrest. I invite you to also view our website after this event and tune in for the other live events we have planned. And so I have the immense privilege of being joined by some of the greatest leaders and innovators in out-of-hospital cardiac arrest survival and AED accessibility and use. Our guests today are truly exceptional, and they are world-renowned authorities in improving cardiac resuscitation outcomes. Everyone on the panel here today works towards a common goal of maximizing survival from sudden cardiac arrest. I'd like to introduce them individually for those who may not know them. So our first panelist is Dr. Stephen Brooks. He is a clinician-scientist and an emergency physician in the departments of emergency medicine and public health sciences at Queen's University. He's also led the implementation of the innovative smartphone app called PulsePoint, which we'll be discussing later on today, in several Canadian jurisdictions. And he's also the principal investigator for a randomized controlled trial that is currently exploring the efficacy of PulsePoint. So welcome, Dr. Brooks.
Thanks so much, Carla.
Our second panelist today is Dr. Sheldon Cheskes. He is a family and emergency medicine physician. He's a full professor in the Department of Family and Community Medicine at the University of Toronto. He is a scientist at the Li Ka-shing Knowledge Institute at the St. Michael's Hospital in Toronto. And he's also one of the principal investigators for the Canadian Resuscitation's Outcomes Consortium that many know as CanROC. Hi, Sheldon.
Hi, Carla. So glad to be here.
Our third panelist is Dr. Dave Williams. Dr. Dave Williams is a huge legend in the McGill community, and he's an ambassador for World Restart a Heart McGill. He's also a returning panelist. He is a Canadian physician mission specialist from 1992 to 2008. Dr. Williams completed his medical degree here at McGill University and practiced as an emergency physician. His clinical research in the past has included evaluating the initial training and skill retention of bystander CPR and patient survival from out-of-hospital cardiac arrest. Today, he's the best-selling author of two amazing novels, Defying Limits, Lessons from the Edge of the Universe, and Leadership Moments from NASA, Achieving the Impossible. Welcome, Dr. Williams.
Thanks. Yes, thanks very much, Carla. It's such a pleasure to join the panel today. And thank you so much for all your work in coordinating this and to all the other students that are involved. It's an amazing project.
Thank you for being here. Our final panelist is Dr. Farhan Banji, who is the chair of our steering committee and has helped the student committee tremendously with coming up with the live events and organizing this campaign week. Dr. Banji is a pediatrician. He's also a professor of pediatrics. He's the director of education at the Steinberg Center for Simulation and Interactive Learning, and he's an associate member of the Institute of Health Sciences Education at McGill University. So welcome to all our panelists.
Thanks for having me, Carla. And honestly, echo Dr. Williams' remarks. What a pleasure! What a great group to work with. I think we're blessed to have such great students at McGill that are leading this.
So to set the tone for today's talk and to give the audience a little bit of a taste of what World Restart a Heart is about and some of the work we've done in the past, I'd like to show a video that the student and steering committees created last year during the 2020 campaign, which teaches viewers how to respond to cardiac arrest in 1 minute. So in the next 60 seconds, I invite you to learn how to save a life.
In Canada alone, every 12 minutes, someone suffers from a cardiac arrest. If you don't do anything, they are going to die. In the next 60 seconds, we're going to teach you how to save a life.
If you see someone lying unconscious, the first thing you want to do is check if they're responsive. If they are not responsive and not breathing or breathing abnormally, they are likely suffering from a cardiac arrest.
Call 911, let them know that someone suffered from a cardiac arrest, send someone to find an AED if there's one nearby, and then start chest compressions.
For chest compressions, find the center of the chest, put your dominant hand down, interlock your fingers, and push hard and push fast.
Using an AED is really easy. You just apply the pads, turn on the machine, and follow the voice instruction. The machine will analyze the rhythm and tell you if a shock is recommended.
I love that video, and we got a glimpse of Farhan in there as well. All right, so because this talk is advancements and improvements centered, I'd like to start by highlighting some of the gaps in knowledge or setbacks in CPR quality and AED accessibility that may account for the current out-of-hospital cardiac arrest survival rate, which is very low. It's only 10 to 12%, and that may have fueled some of the innovations that we will talk about today. So we know that most deaths occur because people are just too far away from the tools they need to save a life, specifically defibrillation, which should be available within the first 2 to 4 minutes of sudden cardiac arrest. Dr. Stephen Brooks, this is exactly where the PulsePoint app comes into play. Can you explain to our viewers who may not be familiar with the app how it increases bystander CPR and defibrillator use compared to normal standard dispatch procedures, really from the moment the app user is notified all the way until the paramedics or the firefighters arrive at the scene of emergency?
Yeah, absolutely. So this is a mobile device app that uses the concept of crowdsourcing. And it's really a way to link people in the community who are willing and able to do chest compressions and might also be willing and able to use a defibrillator if they come across someone who's unconscious and not breathing normally, who's suffering a cardiac arrest. And the PulsePoint app essentially links those people who might be walking around in the neighborhood of a cardiac arrest when it occurs, and it links them in with 911 dispatch in such a way that when an event like that is called into 911, the usual approach of sending ambulances and fire trucks is, of course, very important and gets professional responders moving towards the scene quickly. But unfortunately, it takes 6, 7, 8, in some places 15 or 20 minutes in rural settings for those folks to get there on the scene. And what PulsePoint does is it looks for app users who are within 400 meters of the emergency and who might otherwise be unaware of it. They might be around the corner on a different floor or just not within direct line of sight. And what this app does is it takes those people, it sees the app on their phone, and it alerts them with their own dispatch that occurs through the app. And they get an alert telling them where the emergency is, routing them there, and also will notify them of the nearest registered AED. So it gives people an opportunity to get bystander CPR and defibrillation started immediately, really reducing that delay to that life-saving treatment, and then allows the paramedics and firefighters to continue their journey getting to the scene and take over when they arrive. But it's that delay to chest compressions and defibrillation that is really critical in determining whether someone survives or not. So PulsePoint uses crowdsourcing and willing and able people in the community who have it on their phone to shorten the delay and potentially save a life.
That's incredible. That's incredible. Thank you for sharing. Dr. Cheskes, your passions and research interests also lie in improving AED accessibility and use. And this is especially apparent in some of the work you've been doing on drone delivery systems, especially in rural or remote settings. Today, AED use is very low. It's only 2 to 3%. In many cases, not only do people have a hard time seeing the AED as an easy to use tool, but a lot of the times people can't locate the AEDs. So you chose to fix this problem by bringing the AED to the bystander as opposed to the bystander going to the AED.
Yeah.
How did this drone delivery system come about? Were
Yeah.
drones used in other settings?
Yeah, so listen, it seems like this question comes up all the time that we do this. And I think when we looked at this first, Steve worked with me and worked with Tim Chan and one of our engineers at U of T. And basically we tried to develop a model, a mathematical model, where we modeled all the cardiac arrests in Southern Ontario. And we said, okay, if we put geospatially mapped drone stations in a variety of areas in Southern Ontario, could we improve the response time on a mathematical model? And we found that we could reduce response time at the 90th percentile for rural cardiac arrest by almost 7%, almost 11 minutes in actual rural areas. Now, rural areas have such a long response time. Most rural areas don't realize that their cardiac arrest survival is almost zero because we just can't get there quick enough. So we said that if the mathematical modeling makes sense, is it feasible? And we basically I partnered with two drone companies, Drone Delivery Canada, Indro Robotics, and we basically did mock 911 flights where we compared an EMS response versus a drone response to the same mock 911 call. And in all 8 calls we did, the drone got to the area quicker than actually the EMS response in the same geographic area. So we knew, hey, this is feasible. Now it's time to sort of see if we can actually implement it. And these are the next steps that we're doing right now. So right now we have a number of test flights occurring next week in Muskoka, where we're actually going to be doing flights in Muskoka where long EMS response time. One of the flights is going to be on an island where you can't get an ambulance to no matter what in a serious time frame. And the difference in our flights now from a Transport Canada point of view is a pilot has no idea of the location of the cardiac arrest. And that's much more compatible with the standard 911 response. Our previous flights, all the locations, all the airspace was mapped out, not this time. And I think that's going to be able to show us, can we get there? One little piece I'll add, because I think it's really important, is what do the rural communities think about this? And we did some qualitative research, asked the community, what do you think of this? And the most amazing thing about that is the community at the end of the day said, we love drones, but how the heck do you use an AED? And that to me is the essence of what we're trying to accomplish right now. I think, and me and Steve are on the same page here, we've put AEDs out there everywhere. Yet the use and survival through use of AEDs is still incredibly low, and it needs to be as simple as possible. In one of our last flights, I'll just finish with this, we actually affixed to our AED drone, so to the AED, a FaceTime app. And what we did was when we actually dropped the AED from the drone, the provider actually had visually assisted CPR. So the telephone dispatcher could see the provider at the same time. They said, Dr. Cheskes, we've never had anything like this. It was much superior to telephone assisted CPR, and it felt to the provider like they had someone there with them. I think those are the types of things we need to think about and look at in terms of improving the use of AEDs by providers. We need to demystify the whole process. To me, I'm going to be able to get a drone somewhere, I can tell you that, but someone at the end of the day needs to use the AED, and that's the key to this whole process.
Yeah, I completely agree. And it's amazing that you guys went to the communities and asked them if they were able to use it, because that's super important. Excellent.
Thank you. Thank you.
Dr. Williams, one of the things I hear a lot from friends or family is they're scared to intervene during cardiac arrest. You know, fear plays a huge role in the hesitancy that non-healthcare professionals experience when faced or life or death situations like sudden cardiac arrest. And cardiac arrests are especially difficult to manage because they're so unpredictable. They can happen to anyone at any age and really at any time. And we don't really have a lot of say on the unpredictable nature of sudden cardiac arrest, but we do have an impact on the outcomes, and we can favor survival. And so from your experience dealing with fear or dealing with setbacks and then ending up living a life people can only dream of, what can you say has helped you overcome fear? And how can we translate this to the school teacher or the hairdresser to help them overcome fear?
Well, certainly in the world that I work in, we overcome fear by training, and we train in the normal operations, we train in nominal operations when things are not going well. But the important message for anyone that's interested in getting involved in a situation of cardiac arrest is to get involved, to do something, to act. And yes, you may feel a bit of fear and worry at the time, but afterwards, you will also have the sense that you were able to help out and help contribute and potentially save a life. If you don't get involved, if you have that thought and you become overwhelmed by fear, many people are dealing with guilt afterwards and thinking, oh, if only I had done something, I might have changed the outcome. Today's technology is remarkable. These automatic defibrillators are getting smaller and they're getting smarter. And really, there's not a tremendous amount of technical knowledge that's required. If you simply follow the directions, do what you're told to do, you may have a significant opportunity to save a life, because it's the time to that early onset of defibrillation that makes a difference.
Exactly. Yes. Thank you so much for that answer. Our next question is again for Dr. Brooks. In today's market, I was doing a little bit of research, and I saw that there are a variety of apps and text alert systems that facilitate and accelerate bystander intervention. These technologies either notify or guide bystanders to areas of suspected cardiac arrest in order for them to initiate CPR while waiting for first responders to arrive at the scene. And you actually collaborated with one of our steering committee members, Dr. François Champlain, on a review which identified and classified all the available technologies today on the market worldwide. One of the interesting differences between these apps is that some of them allowed participation regardless of first aid training, whereas others were intended specifically for off-duty healthcare professionals. Can you comment on some of the differences between the apps available today and some of the unique features of PulsePoint as well that distinguish it from other systems?
Absolutely. So first of all, I'd just like to say that it's so exciting to see all of the innovation and creativity, and to see our engineering colleagues and computer science colleagues getting into this space. PulsePoint was a prototype. It was kind of the first one out of the gates from California in the US. But since then, we've just seen an explosion in innovation. And each app that is coming on the market after PulsePoint has little tweaks to it and little differences in functionality. And it seems to be improving upon what was a fantastic initial idea. And now there's all sorts of other ideas about how to maybe make this more effective. So you're right, there's so much variety out there. And some of these apps that you'll find out there, like PulsePoint or Good Sam in the UK, have really been successful at getting a lot of markets and have a lot of users and a lot of EMS systems that have adopted these things. Others are still looking for their clients and still in development and getting out there. So there's a lot of them, but only a few of them are really kind of in action. And you're right, there's a variety in the philosophy behind the app and the philosophy behind the crowdsourcing. Some, like PulsePoint, have essentially a wide open door. There's no barriers to you signing up for this. If you personally feel confident that you would be willing to do chest compressions and for the 6 or 7 minutes before the professional responders arrive, then you can sign up for PulsePoint if it's active in your community. You can put it on your phone and you can be the next hero of the day. You'll get notified, you can go and you'll do chest compressions. Other apps have taken a different approach where you have to show your CPR certification card, or you have to show your hospital ID, or some form of identification that reassures the app managers that you are trained in CPR. And these are really two different philosophies. With the trained group, with the apps that require you to have some level of certification or verification, we're going to limit the number of people who can sign up and create a little bit of a barrier there. But you might expect that when the users are called to the scene, they might be providing better quality CPR or more confidently or more consistently. Maybe that's a question mark. With the open door, where you don't need any certification or proof that you've been trained, you might get more absolute users and more opportunities to get people to the scene, and you may give up a little bit of quality in the CPR that's provided. If you want to know what my opinion is, I think the open door policy is the right way to go, because our expectations as of right now are that any citizen would step up and try to help in this situation, maybe with the help of a dispatcher. But that's our expectation, is that this is something that is a life skill that everybody should be comfortable to go ahead and do. I do acknowledge that it can be a stressful and sometimes frightening situation, especially for somebody who has never experienced something like that and has no medical background. But as Dr. Williams was saying, this is something that if you step up, the rewards for that person on the ground and yourself can be immense. And doing chest compressions and using an AED, although it seems potentially frightening at the outset, is actually, there are quite simple things to do. So I'm a fan of the open model with no certifications, but you're right, you'll see all different kinds of approaches to signing up users on these apps.
Yeah, sudden cardiac arrest is an extremely traumatic moment. I mean, the person is dead in front of you, so it really can't get any worse than that. And
Right.
not intervening, I think, makes it an even more traumatic event. So being able to contribute to their survival is
100%. Any CPR is better than no CPR.
great. The next question is for Dr. Farhan Banji. So, as a pediatrician and leader in resuscitation education for the Heart and Stroke Foundation, chair for the Educational Science and Program Subcommittee of the American Heart Association Emergency Cardiovascular Care, and co-chair of the Education Implementation Teams Task Force of the International Liaison Committee on Resuscitation, you have been involved in some groundbreaking work when it comes to CPR. What are some of the advancements that you've seen in resuscitation that you've seen implemented throughout your career, from changes in CPR protocols to improvements in CPR quality? How has CPR evolved from your time as a medical student or as a resident to now as a staff physician?
Thanks, Carla. That's a great question, and I'll start off by really talking about what hasn't happened and what people sort of expect to happen. And I think what hasn't happened is that there's a magic bullet, that there's some new medication that's going to help, survival in cardiac arrest. Even the value of, tried and true epinephrine has come into question because it's probably not quite as, it probably does help, but it's probably not quite as important as, as we once thought it was. And the idea that CPR is related to that new scientific discovery may be overblown. And I tend to think of CPR the way that it's been outlined by the International Liaison Committee on Resuscitation, is that your survival is going to be affected by three factors. The first one is going to be the science, and that science moves, but it moves slowly. And there's been, in my mind, there hasn't been a earth-shattering new thing that we've done there. It's the implementation and the ideas that you're hearing from Sheldon, Steve, from Dave Williams, around how you overcome fear. How do you get the right people to providing CPR when it's needed? How do you get the right equipment, the AEDs, to people at that point in time? And then it's the education, and how do you improve that? That's the third leg, again, is that education piece. And it's sort of those three things multiplied together. It's that science times the implementation times the education. And the way I conceptualize it is, you think about it in two ways. The first is thinking about CPR outcomes related to out of hospital cardiac arrest. And there, what you really want to do is just what Steve said, was improve the number of people that are providing CPR. Overcome the fear that Dr. Williams just spoke about, and get the AED to people like Sheldon spoke about, and get that information out there. That doesn't have to be a course. We've talked about it, previously, and I think there's been a bias towards, people taking courses and being certified in them, but you don't have to do that to know what to do in that emergency. The brilliance of what our students have done with the World Restart a Heart is they've taken social media, little snippets, and brought to people's attention what you can do to help save a life. 1 minute video, some infographics, Instagram, Twitter, Get that out there so people understand. And if you think scientifically about education, you're way better off, rather than spending 4 hours in a course, is to perhaps spend an hour or two every year and think about it. So where we need to go is having every student that graduates from high school, every graduate of McGill, to have taken CPR training, and let them take a small amount and repeat it a year later, and repeat it a year later. Maybe World Restart a Heart is the day that they go back and refresh and think about this. In Canada, I would argue, maybe we can link it to driver's licenses. Maybe we can link it to your health card, something along the way there. Or maybe it's just high school graduation. We're moving towards that, but we know the kids can save lives. And if you get them early, even though they're not likely to see a lot of cardiac arrest, and keep them training, they're going to get better. And so I think that's one key piece. The other, I would say, is thinking about the in-hospital cardiac arrest. And we're not here to really focus on that, but almost half of the cardiac arrests happen in hospital. And thinking about hospitals and healthcare systems and how they respond. There, it's not just about action; it's about improving the quality of action that they provide. So, poor CPR for a healthcare provider is a preventable harm. No CPR in the community is a preventable harm. So we need to get action in the community, but better CPR for healthcare systems and hospitals. And I think that's training for performance. I would defer to Dave on this one. All the training that astronauts go through and all that they simulate and all the work that goes into their practice, we need to be better at that as healthcare providers. We need to simulate in a contextual way. And I've heard him speak about how they do CPR, in a spaceship. And I hope that we have some time to talk about that. That's phenomenal, but we need to contextualize our learning, get people to practice that. The other thing is we need to just do simple foundational things, just like we've talked about for out of hospital. In hospital, we look at data. How did we perform? Let's debrief that event. Just simply debriefing the cardiac arrest events that happen can improve the outcome for the next patient. Joining a registry and looking at our data compared to our colleagues and saying, how do we improve? And a quality improvement approach to that will save more lives than any drug will in the next 10 years. And that's fundamentally what it is these are innovative ways to build the foundation. Some hospitals perform much better than others. Let's find out what those outliers are doing and try to copy that, emulate that. Some of our research has shown that cardiac arrest survivals are worse at nights and on weekends than they are during the day. That's not right. That's because of our staffing and our way of dealing with things. We've got to do better for our public. And so I'll those are the things that come to mind. And I'd love to hear others' thoughts as we go along if we have the time.
Thank you so much for that incredible answer, Dr. Vanji. I agree. We have to target people early and we have to target them regularly. Dr. Williams, would you like to give us a little bit of insight onto some of the training that you've done as an astronaut that Farhan alluded to?
Yes, well, there's no question as astronauts, we train a lot with simulators, and there's a tremendous opportunity to become familiar with procedures. I really want to underscore that we don't need a tremendous amount of training to use an automatic external defibrillator. That's one of the things that's been so amazing over the last 30, 40 years, is that the technology is getting better and better. So yes, I totally agree with the comments about using simulation and using that more often, making sure that we improve the quality of in-hospital cardiac arrest response and resuscitation. But I just want to go back to 1979, right? I started medical school in the last millennium. This was a time when we had no smartphones. If you wanted to make a phone call, you had to have a quarter in your pocket and find a payphone and run down the street and, try and activate 911. And in those days, it was tough. The technology of defibrillators was based on manual technology. We didn't have automatic external defibrillators. And then you fast forward to today, we have all this incredible technology, tremendous opportunities if it's used. And I think one of the challenges that we face is to have everybody in the community develop that sense of, I'm here for the community as well, that I'm willing to step up, and if there's something that happens, I'm going to make a difference. And how do we do that? Well, we were talking about that earlier. Let's incorporate this into high school. Well, how can you graduate from high school and not know how to use an automatic external defibrillator? And the important part is it's not that you're going to retain 20 years later how to use an automatic external defibrillator. It's that you have an opportunity to overcome that initial fear, that response, that reluctance to get involved, and realize that you can save a life. And that's one of the most remarkable things. For me as an emergency physician, as we have with all the panelists, we work in a clinical environment where this is part of what we do on a day-to-day basis. When you're outside of that environment, it's different. I remember studying my space shuttle crew operator's manual 2 weeks before my first space shuttle launch. The doorbell rings. And I go to the door and the person's standing there looking extremely distraught and they say, "Do you know CPR?" I didn't think this was a survey for the American Heart Association. So I said, "Yes, I do. In fact, I'm an emergency physician." They said, "Oh, good, please come with me." Go running down the street, and in the driveway, an 18-year-old girl had collapsed in respiratory arrest. Now, she didn't have a heart attack. She had really bad asthma, status asthmaticus, had a respiratory arrest, and was on her way to having a cardiac arrest if nobody intervened. But the bystanders didn't really know what to do, so they went and got help, which is one of the important first things to do. If you don't know what to do, get somebody who might be able to help you. And we were able to save that individual's life. They came back and talked to me a couple weeks later, and it struck me how remarkable that gift is. Just with a little bit of confidence and a willingness to try, with today's technology, we have all sorts of opportunities to be able to intervene and save a life. So it's something that really is important for all of us to be willing to say, yeah, I'm going to get involved. And more importantly, we've talked a lot about cardiac arrest. How about stepping in before the patient gets into cardiac arrest? If you see somebody and you're at a restaurant and they're turning blue and they're clutching their chest and they may still be breathing, but obviously they're not well, just simply talking to them. How often on airplanes when we see people running, towing their luggage to get on the airplane, they sit down on the airplane and they're kind of clutching their chest and pale and they're sweating and everything. Well, simply asking, how do you feel? Are you okay? Before they have an event, that can make a big difference as well. So it's basically, an opportunity for all of us to be there for each other in that time of need.
That's an amazing story. And I completely agree. We have to get that initial barrier out of the way, and then people will feel more comfortable to intervene when need be. Thank you so much for those amazing answers. I'd like to go back to Dr. Cheskes. So your novel approach to AED delivery at the scene of a cardiac arrest is really extraordinary. One of the biggest advantages with using drones is that they can be used in what you call beyond visual line of sight conditions. So that means the pilot can fly the aircraft beyond his sight. However, one of the first things that comes to mind, especially in Canada, is the impact weather plays on drones, especially extreme weather conditions like we have in Canada. This being considered, in what settings do you see the drone delivery system to be the most successful? And do you think this can be something that can be implemented worldwide?
Yeah, so first of all, there's no question this can be implemented worldwide. Like, I think when we put this together, we saw this as an opportunity for rural communities across the world to actually use this particular type of technology to respond to cardiac arrest. And the Swedes have just published some work where they've actually done what I want to do, and they actually started sending drones in a particular geographic area as part of the 911 response. And in 92% of the cases they sent them, the drone actually got there first. But guess what the kicker is? No one used AED delivered by the drone prior to EMS there. So that's where our solution comes in, and the importance of this is not just simply getting a drone to someone, it's actually making the process easier to actually apply an AED. When you're looking at drone functionality, cold weather is not an issue. So we've flown in minus 40-degree weather. It's not an issue. Night we've flown in, rain we've flown in. The biggest issue are two things: cell signal and wind. So high areas of wind, you're not going to be flying a drone in those. Certain cell signals, you're not going to be able to fly drones. So we've mapped out different areas of Northern Ontario, and we've mapped it out according to cardiac arrest incidents, but also cell signal. And then if you lay the map over, you know that there's certain areas you're not going to be able to get the drone to because of the lack of a cell signal. But listen, those are smallish areas, but they are areas to watch for. The other area is Transport Canada regulations over airspace. So you're not going to be able to fly near airports, but that's okay because most airports are not in rural areas. But what you have to watch for is the local flying clubs, because those are not those are things that we can't see on the dispatcher, on the drone flights screen in terms of that. We can see all commercial flights, but you can't see that local flight. So those are the areas you got to be careful about when you're looking at using drones. So temperature is not an issue. Beyond visual line of sight, I think, is critical. So all the flights that we have, we launch a drone. The base could be 100 kilometers away. We could fly a drone in Calgary from our base in Toronto. So because we see all the airspace in that area, so that's not an issue. The bigger portion, I think, is going to be what makes it feasible. And feasibility is key because at the end of the day, right now, all my work is grant funded. But eventually a region, a municipality, someone's going to have to pay to actually have this happen. And then to do that, can you just focus on cardiac arrest alone? I believe you can't. I think you're going to need to expand that. So in our flights I talked about, we actually have created a medical drone. And that drone contains not only an AED, but epinephrine for anaphylaxis, naloxone for an opioid overdose, trauma kits. So we have a trauma band-aid. So we're going to be launching a medical drone because we feel that in time-sensitive emergencies in rural areas, you can't just fly to cardiac arrest. There's not enough of them to make it a viable solution. By expanding the indications, we feel that that's going to be a much better bang for the buck down the road and much better for the healthcare system as well. So I think this is something that if we can show it works, you're going to see it in rural areas everywhere. The first thing you're going to need, Carla, the first time a drone-delivered AED is applied to a patient and a patient survives cardiac arrest, this whole area will explode. I can guarantee you that. And we're getting close, but I think that's the goal down the road.
I can't wait to see that happen.
Thank you. Thank you.
Tremendous. Coming back to Dr. Williams, being an astronaut and working for NASA, it's all about pushing the boundaries of technology, of science, of the human body. When you enter an unfamiliar environment, how can you remind yourself that you're ready for what's to come? How did NASA reinforce your expertise and remind you that you're prepared for the challenges that will present themselves? Because when it comes to intervening as a bystander, even with proper training and certification, as we've mentioned, people don't feel ready. So how can we influence this?
Yeah, we of course have to be ready for a wide range of circumstances. As an astronaut, certainly as a commercial pilot, I face the same challenges, and arguably as a clinician, I face the same challenges. I think one of the unique elements of being a bystander is to understand that you can make a difference at any level. So if you're making a difference simply by activating the system, that is actually helping out. And just simply remembering to activate the system is a very good thing. Now we've got these apps. These things are phenomenal. Where's the closest defibrillator? I don't know. Well, now I get on my app and it's right over there. Let's go get it. So all of a sudden you can begin to make a bigger difference. So yes, I think it's a great idea for all high school students to be CPR trained, everybody in university to get the same thing, for all of us to become familiar with using automatic external defibrillators. But if I look at what I do in space, I'm highly trained and I go and do it. In this situation, we're providing people with training, and then there may be a very long time period before which they may use that training. In fact, you might go your whole life and never ever use that training, which probably most of us would be thankful for not having to have to use it. But that's where I think just understanding that part of the training is your willingness to commit to doing something. And whether that doing something starts by activating the system, whether it starts by symptom recognition and preventing signs of ischemic heart disease from going on to an overt cardiac arrest, all of these things are opportunities to get involved and make a difference. Of course, when I'm in space, I'm there as an astronaut, I'm there as a physician. And we develop resuscitation procedures for microgravity. We have to understand how to perform CPR in microgravity. And it's the same on board the International Space Station. The defibrillator is located in one module. If somebody electrocutes themselves and has a dysrhythmia or their heart stops beating, we would start doing CPR in 0G while you go and get the defibrillator, just like we are doing on Earth. So the principles are the same, whether you're in space or on the ground.
Thank you so much. It's great to hear from your perspective, being an astronaut and a physician. It's things that we don't hear very often. So thank you for sharing.
Oh, my pleasure.
Dr. Brooks, coming back to you. We know AED placement in public locations, especially in places where there's high volumes of people, can significantly increase the likelihood of survival from out-of-hospital cardiac arrests, just by facilitating bystander defibrillation. When it comes to optimizing these AED locations, what are some of the factors to consider? What truly are the best locations for AEDs in communities?
That is a great question, and it's one that you should ask as a scientist if you're sick of working with just other doctors, researchers, because this problem really is a juicy one for people other than physician researchers. And what I mean by that is this is a problem of logistics and optimization. This is a problem of understanding where cardiac arrest risk is in the community, and then trying to position the asset, which is the defibrillator, in those areas where you're most likely to need it. So I had the great opportunity of hanging out with these other types of researchers. And when I spent a year on a sabbatical in Scotland, and one of the main events for my sabbatical there was organizing a meeting to talk about just this. And it involved not only emergency doctors and resuscitation geeks like us, but it also involved engineers, mathematicians, human factors experts, architects, and sort of urban design folks who think a lot about signage and wayfinding and these sorts of problems. And we all sat in this beautiful cathedral in Scotland, and we had it out, and we talked about this problem at length. And so I wish you could have all been there, because to hear from the people who don't think about this from a medical point of view, because this is really not a medical problem, this is a logistics problem. To hear them think about this problem was just a mind-opening experience for me. So with all that sort of in the background, to sort of get at some of the answers that I heard from this group of fantastic experts, really this is about this is only one part of the puzzle, by the way, putting the defibs where we think they're going to be used most often. This doesn't deal with the issue of like when we need them, how we're getting them and retrieving them, and making sure people know that they're there. Those are other issues, but it's important to think about the context of the specific question you asked, where to put them. That's only one piece of the puzzle. But to answer that question, it's really about understanding risk for cardiac arrest. So in the past, I think when we look at the history of public access defibrillation, most of the deployment of these devices were kind of put out willy-nilly. Whoever wanted one or whoever could afford one put one on the wall, and that's where they ended up. Organizations are the most common level of client, because they're the only ones who can afford these things. They're very expensive right now. Hopefully that'll change, but now people like optimization engineers are looking at historic cardiac arrest patterns geographically, so figuring out where they have occurred in the last 5 to 10 years, and then making risk maps. And that kind of macro level of understanding where the risk is on a map is step one. Once you understand the patterns of risk on a map, you got to drill down and get down on the ground, on the street level. And that's when you have to ask yourself, is it better to have it inside or outside? Is it better to have it in a place that locks at 5 p.m., like the office building locks their front door at 5 p.m., versus in somewhere like an ATM that's 24 hours open? So these are questions, I think the answers there are probably obvious. The better place to have it is outside, where it's very visible and always accessible, and not behind a locked door. So we've got to think about these kind of barriers. And the other aspect to this, where should we put them, is building type. And that has to do with you can think of all the different kind of types of buildings in the public space, and they differ by footfall, like population density per hour. And they also differ by what kind of activities are going on in those buildings, and what are the demographics of the people who use those buildings, and what is their individual risk for cardiac arrest. So we found in some research, for instance, that if you look at schools versus you look at an airport, you can probably guess which place has a higher risk of cardiac arrest, or a hotel versus a school. The hotels are much higher risk than the schools because they have lots of people hours in them and they have older people versus the schools have younger people. So knowing the building type and the risk for each building type might also help you decide on the micro level about where to put these things. So it's some really interesting research questions, and I think our understanding of this is still evolving, but those are some of the factors that we're realizing are probably important to help you decide where to put them.
And it's very interesting that people are questioning these things. They're not taking the locations for granted and accepting the status quo. People are asking themselves, is this truly the best spot for an AED? And that's incredible. And that's an important piece of the puzzle.
I agree with you.
Coming back to Dr. Banji, as the Director of Education at the Steinberg Center for Simulation and Interactive Learning here at McGill, can you think of ways that CPR and AED simulation training can be improved and better implemented throughout society? What do you think are the current barriers to access such training?
That's a great question, Carla. I think I would start and sort of think about, have everybody reflect on what their own personal best education was. And what I mean by that is the best education you have wasn't just somebody talking to you. It was about somebody involving you. And it wasn't just about engagement there. It was really speaking to both your brain and your heart. And there's an emotional layer to this. And to get people to act when they're scared, I think there has to be some sort of that emotional buy-in. I think if you were to frame this to the public, and I hope that nobody's offended by this, but if you were to create a situation and talk to the public and say, look, imagine a situation where you go in and your loved one is on death's door, and the physician and the nurse that are there said, I've got a way to double or triple your loved one's chance of survival. And then they said to you, but that would have taken me 20 minutes to learn. So I really didn't want to do it. And you have to live with that. Well, that's essentially what we're asking for, is to people to spend 20, 30 minutes to learn how to do CPR. And that's where it doubles or triples the chance of survival. It's way bigger than any effect we can have in a hospital setting. We can struggle and we can make outcomes a little bit better by training, by doing all these things. But where it really matters is that ability to act in that moment. And what we need to do better is to emotionally engage people, to say, look, we don't want this to happen to anybody in your family, but we want you to be prepared. The partners that we haven't spoken about are our cardiac arrest survivors, and our partners that are people that have lost someone to a cardiac arrest and are willing to speak about that. And our student group has really, really nicely engaged a survivor from cardiac arrest, our colleague Patricia, as well as somebody who's lost someone to a cardiac arrest, and to speak about that and to say how important it is to know that their loved one had that chance, that opportunity, because you don't want to be in that situation and live with that. And that's an important thing. I can't think of anything more important than that. If you were to ask the public, and this is scary because there's four qualified physicians on this call, and Carla, you will be, but none of us have to necessarily be qualified in CPR to work. And how's that possible in this day and age where physicians, other healthcare professionals don't have to know this? I think this is probably one of the top priorities that a public member would expect of us. So how do we not mandate that and live up to that? The other thing that gets at performance is the brain. And I think that Dr. Williams has already alluded to this. It's about simplifying. It's about getting things clear. You're not an expert. What you want to do is put your hands in the center of the chest, push hard, push fast. I don't care that you pushed exactly 5 centimeters. I don't care that your rate wasn't exactly 100 to 120. I do care that you tried something And I do care that you listened to the person on the end of the EMS call, like the 911 dispatch, who told you what to do, and you listened, and you got somebody else to go get an AED, and you followed the instructions of that AED. We need you to act, and that's the critical piece that has to happen. So it has to be simple for them to be able to remember that in a crisis. It's tough for all of us that deal with crisis every day to remember everything. So we've got to simplify it and say, okay, this is what you need to do, and just that. Push hard, push fast, get an AED. If you're trained, take a 20-minute course. Take CPR Family and Friends from the Heart and Stroke Foundation of Canada. Take those simple things that make you better. A barrier for many people is spending 4 hours at a course. And you're probably better off to spend 20 minutes every year than you are to spend a 4-hour course once and then everything that you forget. The last thing I'd say is that we need to support people that provide CPR. And it's a hard thing to do. It was emotionally challenging. It was a witnessed event. And it's highly emotional where you don't even know, in some instances, what happens. And a close colleague of ours, Katie Dainty, is doing some amazing work in supporting people that provide CPR and helping them, to understand the importance of what they've done and helping them cope on some of the things that they've gone through. And I think that's critical when you've done CPR for somebody that you don't know. The other thing that I think we have to educate people about is, if you do CPR, the highest probability is it's on somebody that you love or that you know, and that you care about, and that's what we need, and that's why we're doing this, to help someone that's close to you. So I'll stop there and open up for the other questions that people might have.
That was very well said. And engaging people emotionally is the best way to engage them, especially because this is something that happens in homes. So having tools on your phone or an AED, a personal AED at home, makes survival so much more likely. So a follow-up question would be, you mentioned, practicing CPR once a year. Do we think that it should be practiced in more regular increments, once a month, at home, or having training kits in people's homes, or do we think once a year is good enough?
Yeah. So the literature says that if you take a CPR course, you start to lose some of those skills 6 weeks, 3 months after you learn them. I think there's a challenge though in that human beings are human beings. So there's going to be a certain frequency where it's going to be innovative, new, challenging, and it's going to engage them. Beyond that may become frustrating and challenging for them. So for healthcare professionals, I actually believe that they should be training every 3 months on the psychomotor CPR skills for all of us. Even if it's just 2 minutes, just practice that. For people that are public, there's got to be a sweet spot. And I don't know exactly where that is, but some of the research from Kids Save Lives and training young children is that sweet spot might be around once a year. I think that repetitive practice is important. We don't know what the optimal strategy within there is, though.
Thank you. Well, it's yet to come, so hopefully we'll find out soon. Moving on to Dr. Brooks and Dr. Cheskes. So both of you contribute immensely to the advancements that we've spoken of today in CPR and AED availability. Where do you envision the field heading in the next 10 years? Will efforts be mainly focused on apps like PulsePoint, or home kits or personal defibrillators at home, or AED delivery systems like drones? We can start with Dr. Brooks.
Well, I have a conflict because I'm involved in a few exciting startup companies that are really going after changing what a defibrillator looks like. So I'll state that out front, that I'm involved with at least a couple of these things. But I think that's where some really exciting changes are coming up in the next 10 years, is that we're sort of fixed with this thing that's heavy, it's very expensive, and it sticks on a wall. And I think advances in technology are going to allow us to change what that defibrillator looks like. And that's going to provide us with new opportunities for how we deploy them. There are companies, several of them, that are working on miniaturizing defibrillators so that they're the size of a cell phone, or even, a few of them that don't have prototypes, but that are, cases for cell phones. And with advancements in battery technology and new proprietary waveforms for defibrillation that require less energy to defibrillate the heart, that's where these advances are coming from. So I think in the future, we're going to see a defibrillator that costs, $100 to $300, has a 2-year shelf life, has 8 shocks in it, so it's single use, and it's meant for somebody's back pocket or in their front closet in their house. And then that's going to change the game for personal access defibrillation instead of public access defibrillation.
Yeah, I'm totally with Steve. So I see us turning the whole paradigm around. Right now, we're doing public access defibrillation. 80% of the cardiac arrests happen in private homes. I see the world moving to private access defibrillation. I'm going to get a drone and I'm going to put it on your front lawn in a rural area. You get discharged from hospital with a large infarct. You're going to go home with a pocket defibrillator. This is where we need to improve it. All our EMS systems are rushing to get to homes, but we're getting there too late. And I think sensors to be able to sense cardiac arrests before they actually occur. Having the private defibrillators that Steve mentioned. So from a drone point of view, I've had a number of companies come to me with defibrillators at 100 grams. You know how far I can take a drone with a 100-gram defibrillator? I can go 30 kilometers with that payload. So this is all going to change. I think the focus right now has been on public access. We need to actually work on the private access, getting to where the cardiac arrests are going to happen more commonly. And this is going to be the stuff that Steve, I, Dave, and Farhan are talking about. That's where really, I think, we really need to make some headway there if we're really going to make a difference.
That's an important mindset switch that we all have to grasp. We have to flip it from the public to the private, and hopefully it'll happen soon. Our last question of the talk is for Dr. Williams. We've been drawing many parallels throughout this event between being an astronaut and being an emergency physician and being human. Since 2018, you've taken on the role of CEO of Leap Biosystems, which mission is to create new technologies to enable healthcare in the most remote locations, including space and rural areas. Are there any techniques or technologies in space medicine that are currently being developed and that can be applied in emergency rooms on Earth? More specifically, are there advancements used in space that may improve our current methods of CPR and resuscitation?
Well, needless to say, the short answer is yes. One of the things the space program has done incredibly well is miniaturize technology, making it smaller and making it smarter and making it more capable, which, as we've heard, is the direction that defibrillators are going in. I love the concept of single-use defibrillator, single-use disposable defibrillator in the home for high-risk patients. That's really what we need to be focusing on. Leap Biosystems is involved in developing augmented reality solutions to enable us to provide high quality healthcare everywhere, whether that's in space or northern communities in Canada. And there's a lot that we can talk about in this area. Just last week, there's a company in Texas that we've been working with that demonstrated holoportation on board the International Space Station. So it's, William Shatner flew in space today at age 90. Well, last week they were literally beaming people up to the space station, a la Star Trek, which is quite incredible. So imagine in a rural community where you can beam any one of the clinical group here today into an emergency department to help out the local practitioner, or to beam somebody at the scene of an incident to be able to then have an emergency physician at your side. This kind of technology is going to be coming. And it sounds like science fiction today, but remember, one of the things that we do in the space program is turn science fiction into science fact. So it's so exciting thinking about this. As you know, we've had drones in Toronto transferring transplant organs between hospitals, a Quebec-based company developing the tech. Again, amazing stuff. So I think in the next 25 to 50 years, the future of healthcare will be transformed by implementing these new technologies.
Wow, that's amazing. I'm so excited to be joining a field with so many so many advancements brewing.
Carla, I want to see, I'm going to challenge Dave Williams to beam out of here when the call is over. I want to see this.
So for our audience watching, thank you for joining. Unfortunately, we've reached the end of this live event. I'd like to thank all of our panelists for being here today, for giving us their time. Dr. Stephen Brooks, Dr. Sheldon Cheskes, Dr. Dave Williams, and Dr. Farhan Banji. Thank you so much for being here, for promoting the importance of CPR, and for sharing some of the amazing things that are happening right now in the field. Thank you.
Thanks.
Thank
Thanks,
you,
Carla.
very much.
Pleasure.
Pleasure.
Real pleasure.
I just want to take this opportunity to advertise our last event of the McGill World Restart a Heart 2021 campaign. It's going to be happening this Friday on October 15th. We're going to hear from Dr. Goldfarb, a cardiologist and cardiac intensivist, Dr. Deschamplain, who's part of our steering committee, Dr. Robert Thirsk, Canadian astronaut and physician. So if you'd like to learn more about that last live event, please visit our website. And thank you for tuning in today.